if you're one of the, millions of people kind of balancing your own life with providing some kind of care, maybe checking in on an aging parent or helping a relative with a chronic condition, just trying to lend a hand, you probably know that moment of dread.
Mm.
You offer some really practical, loving help. Maybe, hey, I'll run your laundry down, or let's check that new blood pressure thing, and bam, that immediate, polite, but really firm wall goes up. Oh, honey, don't worry, I'm fine.
Yeah, it's such an agonizing moment, isn't it?
Yeah.
Because you often know they aren't actually fine, but the conversation just gets shut down instantly.
Right.
Our source material actually gives this really painful example. Mrs. Alvarez, her daughter offered to stay, cook dinner after Mrs. Alvarez had a pretty bad fall scare.
Oh, wow.
And the response was just that familiar refusal. I appreciate it, dear, but I've already handled it. I need you to go home now. It just leaves you as the caregiver feeling so ineffective
Mm-hmm.
and maybe unappreciated, too.
Totally. And when that happens, it's just so easy to fall into that mental loop of, okay, they're just being stubborn. They're defying me. But this deep dive, we really want to fundamentally reframe that response.
Mm-hmm.
We're going to look at that immediate rejection not as simple defiance, but as behavioral resistance, a behavior that, well, it always carries some kind of signal, right? A meaning that we, as the helpers, often miss.
Exactly. And our mission here, really drawing heavily on clinical research and the structured framework of applied behavior analysis, or ABA,
Yeah.
it's to move past that frustration.
Yeah. Okay.
We want to explain the actual roots of refusal and give you some practical evidence-based strategies for, communicating and offering help in a way that really respects the individual's dignity and, crucially, fosters cooperation instead of just shutting it all down.
Okay, let's unpack that first crucial point then. If the refusal isn't just about being difficult, what is the core signal? What's resistance communicating? What are we missing when we hear, I'm fine?
Well, what's fascinating here is that resistance often signals a really core psychological need. It could be fear, a profound sense of losing control, or maybe most commonly, just a mismatch. A mismatch between the help you're offering and what actually feels emotionally safe to that person right then. And the source is really stress. It's rarely just one single cause.
Yeah, I can sort of relate to that just thinking about it. When you offer help, your motivation is love, maybe necessity. But for the person receiving it, it can feel like a direct threat to their autonomy, can it?
That perceived threat is exactly the issue. The sources break down several factors driving refusal. First, and maybe the biggest one, is a loss of independence.
Right.
Just accepting help can feel like you're surrendering fundamental control of your life. It's like the visible proof that you can't do things for yourself anymore.
Wow, yeah. That's a huge emotional burden to carry.
It really is. And second, you've got cognitive factors. So if the person's experiencing, say, cognitive fog, confusion, maybe impaired insight, the help you're offering might feel irrelevant to them, or intrusive, or even actively threatening just because they don't fully grasp the need or the risk involved.
And I guess the more confused someone feels, the more disruptive a new face or even just a small change in schedule must feel.
Absolutely.
Yeah.
Which leads right into the third factor, emotional memory. Past negative experiences with care can be hugely influential.
Oh, interesting.
Yeah, if they felt rushed before or ignored, maybe infantilized in previous interactions, those memories really shaped their current reaction to any offer of help.
So they start associating help with feeling bad.
Pretty much. They associate the offer with discomfort or feeling small, and so they resist almost preemptively to protect themselves.
That puts the current caregiver in such a difficult spot, though. You're kind of walking into a situation that's already colored by someone else's past negative experiences.
Precisely. And the fourth route we see is routine disruption. I mean, we all thrive on predictability, right?
Definitely.
So new schedules, new caregivers, maybe unfamiliar technology, it all disturbs those established comforting patterns. And that disruption causes immediate stress, agitation. And the response is often just no, as a way to try and stabilize their world again.
Okay, so if we pull this all together, the critical shift for the caregiver is seeing that refusal as communication, not defiance. They're communicating this desperate need for predictability, for dignity, for a sense of managing their own life.
Yes. If you can just hold on to that one insight, that they're protecting something valuable, not trying to sabotage you, it makes the next steps, the analytical steps, much easier to handle.
Right. Which brings us to the science of how we actually analyze that communication. And this is where applied behavior analysis, ABA, gives us a really helpful structured framework for looking at why a specific refusal behavior is happening.
Yeah, ABA helps us break down the behavior of refusal using something called the behavioral loop. You might know it as the ABC analysis.
ABC.
Okay. We basically look at what happened right before, during, and right after the refusal.
Okay, let's start with A, the antecedent. Walk us through that.
So A stands for antecedents. This is everything that happens immediately before the refusal. It could be something obvious like the timing of the request, maybe asking them to shower right before their morning coffee.
Bad timing.
Yeah. Or it could be subtle,
Mm.
like the tone of voice used in the request,
Mm.
or even who is asking. Maybe they always accept help from one child, but, never another.
Got it. Okay. And B is the behavior itself. That's the refusal, whether it's verbal, like leave me alone, or maybe more subtle withdrawal, or just plain avoidance.
Correct. And then finally, C is the consequence. What happens right after the refusal? And this is where the really deep insight lies, because this is often where the behavior gets unintentionally cemented.
How so?
Well, if saying no results in you, the caregiver, dropping the subject or reducing the pressure or maybe just retreating,
Mm-hmm.
the person has achieved immediate relief.
Wait, let's pause there. That's kind of the insidious part of this loop, isn't it?
It is.
As the caregiver, you back off because you think you're being compassionate. Or maybe you're just exhausted and want to avoid a fight. So you get momentary relief, too.
That's the double reinforcement trap. You learned that backing off works to de-escalate the tension in the moment. And the individual learns that refusing works to get rid of the pressure.
So you're both unintentionally reinforcing the exact behavior you want to stop.
Exactly. It's devastating, really, because the behavior just sticks and your frustration just keeps building. And this explains why approaches that focus on, sheer persistence or just insisting louder, why they fail so miserably.
Because they just make it worse.
They do. They intensify the antecedent, the pressure, and then they reinforce the consequence when the person finally gets relief by avoiding it. We need to reverse this whole cycle. And we see specific, clear signs in the research that this loop is active. It includes not just those immediate I'm fine responses, but also things like small refusals, quickly escalating into blanket refusals like I won't do anything today.
Yeah, that escalation feels like a huge red flag.
It is. Also, look for agitation when routines change without notice. Or that kind of silent resistance, where they might agree in the moment, okay, but then they just don't follow through later.
Right.
These signals, they aren't personality flaws. They point directly back to that core need we talked about. Predictability, dignity, and control.
Okay, this is making so much sense. We know the roots now, and we know the analytical trap we can fall into. So how do we apply this ABA knowledge to actually communicate better?
Yeah.
We need practical strategies, things that change the antecedent and the consequence at the same time.
Right. Since we've established that pushing harder usually just backfires, the effective strategies focus entirely on changing how you ask and how you react. We have to change the environment and the approach itself.
Okay, let's detail these strategies. Number one sounds simple, but I bet it's powerful, offering choices to preserve autonomy.
Oh, it's critical. Instead of asking a high-stakes, high-pressure yes-no question like, do you want me to help you take your pills now? Which just invites a no.
Right.
You offer two acceptable options. For instance, would you like to take your medication with orange juice now, or maybe with your evening tea in about 20 minutes?
Ah, I see. So they don't really have the option to refuse the task itself, but they get to keep agency over the when or the how. That must feel much safer for them.
Precisely. Strategy 2 is all about changing the antecedent through timing and tone. Using a soft, neutral, non-demanding phrasing that instantly reduces the perceived threat.
Okay.
And timing really matters. Aim for asking after an enjoyable activity when they might be more relaxed. Definitely avoid trying to push during moments of obvious confusion or fatigue or stress.
And strategy 3 is really clever, making the environment, not the caregiver, the one setting the schedule.
Yes, the sources identify this as a really powerful technique. Instead of relying on you to nag or remind them all the time.
Which causes friction.
Exactly. You make the help predictable and less intrusive through consistent visual aids. Things like routine charts, maybe a labeled medicine box right there on the counter, or just set scheduling. The structure itself takes the pressure off the family interaction. The sources call this using environmental taskmasters. The routine becomes the gentle boss.
That makes perfect sense. It's the chart saying it's time for the shower, not, the daughter nagging her mom. It removes that personal conflict element.
Okay.
What's number 4?
Number 4, pair assistance with preferred activities. Basically, you connect the necessary task with something pleasurable they actually look forward to.
Ah,
So
okay.
for example, instead of just saying, time for dinner prep, maybe say, let's fix your tea, and then we can watch that new documentary you love together while we eat. It increases cooperation because you're associating the necessary task with a guaranteed positive outcome.
And number 5 feels essential for changing things long term, reinforcing small acceptances.
Absolutely crucial. You have to use positive reinforcement. Even if they only cooperate slightly, notice it. Praise that effort immediately and specifically.
Like how?
Like, hey, thanks for letting me help you find those keys that made things quicker so we can just relax now. Something like that. It reinforces that cooperation leads to positive attention and, functionally, quicker relief from the task itself. It focuses on the good outcome.
Okay. And finally, strategy 6 is about validation, what to do when the refusal still happens, despite our best efforts.
Right. Slow down and validate emotion. Acknowledge their feelings first. That helps reduce defensiveness. So if they refuse to take their vitamins right now, instead of arguing, you can say something like, I hear that you really don't want to take them right now.
Acknowledge it.
Yes. Then add, okay, I'm going to step away for a bit, but I'll be back in 15 minutes to ask again with some water, all right? This validates their current feeling of control, but it keeps the door open for the necessary task later without escalating things.
Those are 6 incredibly practical, actionable steps. But we do need to touch on the clinical context, because sometimes refusal goes beyond just communication and, well, it becomes a genuine safety risk.
Yeah, this is where we need real clarity.
Mhm.
First off, does saying no automatically mean the person lacks decision-making capacity?
Good question.
The answer is no. Our sources are very clear. Refusal is not the same as incapacity.
Mm.
However, repeated refusals that demonstrably cause harm, like, say, refusing necessary, life-sustaining medication day after day, or critical hygiene tasks that lead to infections that should immediately prompt a clinical evaluation. For capacity, yes, but also for safety planning.
Okay. And what if we find ourselves slipping back into that old pattern, starting to push harder when faced with resistance?
Stop. Just stop. The advice is absolute on this. Pushing harder almost always reinforces the refusal because it heightens that sense of threat.
Right.
The only effective path, confirmed by clinical guidelines, is to alter the antecedent. Change the timing, change the approach, offer that limited choice immediately. Get out of the confrontation cycle.
But what if the refusal creates an immediate safety danger? Like, say they're aggressively refusing help with a transfer and, they're at high risk for a bad fall right then and there.
Okay, if refusal creates immediate safety danger, you absolutely must seek clinical assessment immediately. That's an urgent situation. For the ongoing non-acute concerns, the recommendation is rigorous documentation. Use those ABC logs we talked about.
Mhm.
Involve the primary clinician, share that data, and stick to these gradual, person-centered strategies. Confrontation is almost never the right answer, even when the situation feels really stressful.
And this isn't just about making life, less stressful for the caregiver. The research actually validates that this approach improves health outcomes too, right?
Absolutely. There are clinical studies showing that caregiver training programs, ones that specifically focus on person-centered communication, understanding the individual's personal history, and making those environmental modifications, they successfully reduce the incidence of these refusal behaviors, especially among people with cognitive impairment. The data really confirms this is the most effective way to improve care.
So wrapping this up, what does this all mean for you, the listener? When your parent or your loved one looks you in the eye and says, I'm fine, try to understand they are likely protecting something vital, their sense of self, their dignity, maybe their emotional safety. Resistance isn't usually a deliberate attempt to thwart you. It's more like a powerful, if sometimes misplaced, call for smarter help.
Yeah, it's a call for help that needs to be respectful, structured, and predictable. Help that ensures the recipient still feels like they have some say in their own life, even when they need assistance.
Yeah.
When caregivers can respond with choices, with structure, with sincere validation, that resistance often softens, and the necessary cooperation can actually begin to grow.
And if we connect this back to the bigger picture, the infrastructure of care, the source material notes that programs focus specifically on training caregivers in these person-centered communication strategies report a significant reduction in refusal behaviors.
Which really suggests something quite profound, doesn't it? It suggests that maybe the biggest systemic obstacle to people getting the care they need isn't the difficulty of the behavior itself, but rather the current lack of widespread training in these effective communication strategies for both professional and family caregivers.
That raises a crucial question then for you to think about.
Yeah. If better communication is proven to be the key, not just to less stress, but to better outcomes, what implications does this hold for how we prioritize resources? How should we support everyone involved in long-term care moving forward? It's a conversation we really need to be having at every level.